So today is part 2 of 5 in this boot camp, and we are really going to be taking a dive into serology. And we've actually dedicated next week's talk as well to take even a deeper dive into serologies, because I think this is a really important barrier for some, but learning point hopefully through this process that will help us as providers kind of overcome some of the barriers to adopting more Hep B management in our practices. So the serologies can be a bit confusing, and so we really want to spend some time this week and next week discussing serology. In the case that Dr. Dasu, again, thanks again for submitting, is a case of serology and how to interpret it. And I'm hopeful that we'll actually have time, Dr. Dasu, to also share that YouTube video that you were kind enough to share with us. This is really creating a knowledge network, two-way sharing and learning from one another. So I think it's a great resource after having looked at it. So we're going to talk really about how to break down serology as it relates to Hep B today. So let's get started. So we have a 28-year-old woman who was born in the United States. This is similar to the same case actually that we shared last week that we're going to kind of build through the series. Her parents emigrated from Taiwan 2 years before her birth. Patient met with her primary care doctor to discuss family planning, as you'll recall from that video you saw last week. Although she initially was hesitant and had declined Hep B screening, she ultimately consented to screening for hepatitis B when her doctor explained the consequences of untreated infection and the basis for the CDC screening guidances. What tests do you order for the patient to screen for hepatitis B? And Dr. Dasu, I think your case will be a good one to share towards the end of today's talk. So let's start with keeping that case in mind. What is kind of the first step to tackling serology and screening for hepatitis B? There are really 3 main tests that are used for screening here in the United States for hepatitis B infection. And these are the 3 tests: hepatitis B surface antigen, which is a marker for actual infection, active infection. Chronic hepatitis B, by definition, requires the presence of Hep B surface antigen for at least 6 months. And then the second test is antibody to hepatitis B, a surface antibody. So this is a marker of immunity to hepatitis B. The third test is the total core hepatitis B antibody, which is a total antibody and therefore an IgG. This is positive in persons who have previous exposure. We'll talk about kind of the other ways to interpret this test result in certain scenarios. So false positivity is one way to interpret this test, but 9 out of 10 times it will be a marker for past exposure infection. And then the one caveat that we've included here as an asterisk is if you are suspecting acute hepatitis B, checking specifically the IgM to the core antibody is particularly helpful. And what I'll do is I'll share that YouTube video, Dr. Dasu, towards the end of the talk, because it talked a lot about timing of when these different serological markers can become present. So once you've identified somebody as being surface antigen positive or having active infection, there's kind of a step 2 for additional testing. So this is usually done by bringing the patient back to really try to get a sense of where somebody is with their infection. So the additional tests that we'll often check are the hepatitis B e antigen. This is sometimes felt to be a surrogate marker of a high viral load, which we'll also discuss. And the other tests include an antibody to hepatitis B e antigen, and this can sometimes be associated with pre-core or basal core promoter mutations. When you develop the e antibody and you lose e antigen, this phase, if you will, is often associated with a lower hepatitis B viral load. And then this brings us to the third test, the hepatitis B viral load, which is really checked or ordered by checking a DNA PCR. And this is obviously how we can measure active viral replication. And these three tests really influence how and when we manage patients who are infected with hepatitis B, particularly with respect to initiation of antiviral therapies, which will be something we talk about in more detail in not next week's talk, but actually the talk after that. So let's talk a little bit about interpretation of these serologies and how they line up. So let's go back to step one. And step one, remember, is really what are the tests we check when we're trying to screen or test somebody for hepatitis B. And these tests include the hepatitis B surface antigen, the core antibody, and the surface antibody. So in somebody, which we check all three of these tests, and all three have a result of a negative value. So these tests are reported as negative or positive, or sometimes it'll be reactive, non-reactive. So if all of these are non-reactive or negative, this is somebody who's not been infected previously, does not have any evidence of active infection, and therefore we would describe this person as potentially susceptible to hepatitis B. And as we touched upon in last week's talk, we certainly have a highly effective vaccine to prevent. So in somebody who has this serological evaluation test results, you want to be thinking if they are potentially somebody who could become infected, is it somebody we should be thinking about offering this highly effective hepatitis B vaccine to make them not susceptible. Another interpretation or another test result scenario would be if the core antibody and the surface antibody are reactive or positive while the surface antigen is negative. As I just said in the couple of slides before, if the surface antigen is positive, that means that's somebody who's got active infection. So here it's negative. So this is not somebody who is considered to have active infection. But we do know that the core antibody and the surface antibody come back positive. And the way we interpret this is immune due to prior infection or natural infection. And really natural here refers to prior infection. And that is because really the core antibody is positive here. This is a different situation than the next one I have listed here below, in which the surface antigen is again negative. In this scenario, the core antibody is negative, but the surface antibody is still positive. And this is the scenario you would see in somebody who's immune due to prior hepatitis B vaccination. So really, we know that the surface antibody being present, it goes along with immunity for both of these scenarios. But the way to tell the difference between somebody who's immune from prior infection versus immunity due to vaccine is whether or not a person has the presence of core antibody. And if they do, this is from prior infection. If they don't, in the scenario of being surface antibody positive, this is really a sign that should correlate with a patient reporting to you that they have previously been vaccinated. So what are the other scenarios with respect to these serologies? So we've talked about some of the surface antigen negative scenarios. Let's talk a little bit about, in these first two cases or rows, if the surface antigen is positive. So if the surface antigen is positive, again, that tells us that somebody's actively infected. I mentioned the core IgM test being a test that we can check in the blood, and if it's positive, would go along with a very recent acquisition or transmission of this infection in that person. So if the core IgM is ever positive, that should really be a tip-off that this is an acute case, a case of acute infection with hepatitis B. And this is different than more more often what you're likely to see in the setting that you are practicing, in that the surface antigen is positive, but that core IgM is negative. And remember, the standard core antibody test, unless it says an IgM, is a total IgG test. And again, by definition, to be called chronically infected, that surface antigen needs to be positive for a 6-month period. And so if you were in this catching somebody in acute phase, which often unfortunately isn't something that's done because of the largely asymptomatic nature of infection in most persons, so we don't have the luxury oftentimes of catching them in this acute phase, you could check it within that 6-month period to see if they go on to clear it versus they go on to have infection. And if they did for 6 months or longer, they would fall into a definition of being chronically infected. And in last week's talk, as you will recall, we talked a little bit about the age at which the virus is acquired. So the age at which you're infected really determines your risk of developing chronic infection. And so, newborns who get this from mother to child transmission at the time of delivery have a high risk of developing chronic infection. And this is very different than adults who acquire this infection, in which 15% or so of people will go on to develop chronic infection. And that has to do with the immune differences at the newborn stage versus the adult stage for most persons. And so again, if your core IgM is negative, if you were to check it, the most likely interpretation here would be chronic infected, although by definition you would need the surface antigen to be checked 6 months apart. Not clinically something that we often will do unless we're suspecting a recent acute infection. And then finally, the last scenario, which is one that I wanted to spend a couple of minutes on, is one that often trips us up as providers. And it's confusing and it's difficult to sometimes for us to understand it and then also relay it to our patients. So this is a scenario in which both the surface antigen and the surface antibody are negative. So this is somebody who doesn't have active infection, but the one test that does come back positive is their core antibody. So this is kind of what we sometimes refer to as an isolated core antibody positive scenario. Now, the interpretation can follow more than one, unlike the other scenarios that we just discussed. And I think this is what sometimes makes it confusing. The 9 out of 10 time interpretation of this test is this first point here, is that this is somebody with resolved infection. And I think if you kind of keep that in the back of your mind, that's really helpful. So the vast majority of patients that you're going to see when they get this test result, they're going to fall into this category. It's the most common interpretation of this test, which is somebody who has resolved infection. So they actually were infected. And if I were to show you kind of going back a slide here, again, if you're core antibody positive, right, immune to natural infection. What's abnormal in this scenario when we're talking about it is that most people who are immune to prior infection or have a resolved infection, they typically will have this surface antibody that's positive. And so that's what kind of trips us up in terms of how to interpret this test. Now, there are less likely interpretations to be aware of in this scenario. One can sometimes be a false positive of that core antibody test. And 2, it could be what we call occult or a low-level chronic infection. This is really seen in large part in certain geographic areas of the world, so higher rates of this in our sub-Saharan African populations as well as our East Asian populations. And this is where basically if we were to just do the screening, we would often miss infection in some of these patients. And the only way sometimes for us to tell, the DNA, the viral load will even be negative, but when you biopsy them, they actually have virus that is found in the liver, and that's why it's called occult infection, something that is very difficult for us to tease out and find, and doesn't really follow a clear interpretation on the screening and tests. And then the last scenario is one, again, in the right clinical setting. And so finding out when you're talking to a patient, do they have anything in terms of a recent exposure, a resolving acute infection before you'd have time to develop surface antibody. You could just have the core total IgG test that's positive. And so, again, I think this is the scenario in which we get a little bit, it's very confusing. It can trip us up in terms of how do we interpret these tests, how do we relay it to patients. I think if you keep in mind that the most common interpretation of this test is resolved prior infection, which again is somewhat atypical because you typically would have the surface antibody that's positive, but it's not here. That will help kind of carry you through. And we can take some questions on this as we go or towards the end if folks have some. So what are the lab tests that we check when we're talking about somebody who's surface antigen positive and has hepatitis B infection, chronic infection? So we just talked about there are the serological tests. So step one is the screening test. And if somebody's surface antigen positive, we laid out that we would recommend to check your E antigen to hepatitis B and your E antibody to hepatitis B, along with the hep B viral load, which is measured as the DNA PCR. So these are the other serological markers that we would recommend to check. And then on the other side, in addition to the serological markers, we need some additional information to help guide us, and we're going to talk about this in session 4 out of 5. How do we take all of the information we can gather on a patient and translate that into a management or an action plan for the patient? And so the additional serological markers help us, but we also want to know what is the status of their liver test, particularly the serum ALT test, because this is also used in your management strategy, as well as some type of fibrosis evaluation. And this is really, really recommended for anybody with any liver disease, but particularly important in patients with hep B, because if we see that patients are developing progressive fibrosis, they then shift from just watchful waiting, no antiviral therapy category, sometimes to an antiviral initiation of antiviral therapeutics for these patients. And so we want to be thinking about how are we going to measure or evaluate for fibrosis. And there are a number of non-invasive markers, serologically scores that have been developed, as well as non-invasive imaging tests that include elastography. So tests such as the FibroScan or MR elastography are used more and more in a variety of practice settings. And liver biopsy is still also used in select cases before some of these non-invasive imaging tests for fibrosis. We actually relied a lot more heavily on liver biopsy periodically to see if somebody was developing fibrosis depending on the phase of infection we thought they were in. So doing some type of fibrosis evaluation is really helpful and important, and this can be periodically repeated to see if things are changing over time. So, so when we think about kind of the clinical phases of hepatitis B, let me just make sure, yeah. So clinical phases of hepatitis B, it's really important to have an understanding of where, how to put these markers that we check in the blood with where we think a patient might be with respect to how many years roughly do we think the patient may have had this infection, although no test definitively tells us that information. But it also then correlates with what phase of infection we think that patient is in. And we're going to talk about some of these older phases and terminologies, and we'll talk a little bit on the next slide about some of the newer terms that we now use that have replaced this. But people still have are familiar with some of these older terms which have been confusing, and so we'll start kind of here. So we just mentioned that the tests that we would check for somebody who's surface antigen positive would include an E antigen test, an E antibody test, a hep B DNA, and an ALT level. Typically, when people first acquire this infection, they will be E antigen positive, they will have a higher hep B DNA, and their ALT when they're in this, what we used to call an immune tolerant phase, it will have a low or normal ALT level. And again, sometimes patients don't fit exactly into these categories, but this is rather meant to try to describe how things evolve with respect to infection over time. So again, in an earlier stage of infection, you would expect a high DNA PCR level, a normal ALT, and somebody who's e antigen positive. And then over time, what happens is patients move through an e antigen positive phase to an e antibody positive phase. So you lose the antigen, you develop the antibody. And with this, patients can start to what we used to be called immune clearance, because you lose the e antigen and you develop the e antibody, but the DNA level might fluctuate or come down over time, and you might see that the ALT level goes up during this period. This is then followed by what we used to call the inactive carrier state, which I think was a terminology that was pretty unfortunate because it was somewhat misleading and it didn't really correspond with a level of necessarily needing to monitor or having a management plan around it oftentimes. And then as you go longer with this infection, you can develop more and more progressive fibrosis over time. So the nomenclature has been updated. So I talked a little bit about older terminology of this immune tolerant, immune clearance, followed by inactive carrier reactivation phase. And the updated terminology that's been in place for the last couple of years and is being used more and more is to kind of move away from these terms that don't really denote a lot of meaning of what we should be doing or looking for, with some terms that might be more reflective of what's actually happening in the patient. So again, what you see above is similar to what you saw on the slide before. Again, in an earlier stage of infection, you'll be e antigen positive. You'll then, over time, lose e antigen for most patients and develop e antibody, and your DNA level and ALT level will change as you go through these phases. But we now call what we used to call that immune tolerant phase normal or minimal hepatitis. And then this is followed by kind of a chronic hepatitis phase, and then progressive fibrosis the longer you have. And remember, hepatitis B, certainly independent of fibrosis, can increase your risk of developing a liver cancer. But certainly, as you develop progressive fibrosis, can develop cirrhosis. And in cirrhotics with Hep B, you think of it almost as kind of like a double whammy in terms of your risk for liver cancer goes up quite a bit more markedly than just having hepatitis B alone. So I think what we wanted to do here, and I think time is going to allow us to do this, Dr. Dasu, if you're okay, maybe I'll do is I'll show the YouTube video now, and I think we'll have enough time to discuss the case. So let me actually stop sharing this. And I did like this resource that was shared. So let me go to sharing this short video. It's about 9 minutes, but let's see if we can play it through my screen here. Give me 1 second. Okay. And Rachel, can you see my screen, the YouTube video?
I can, yep.
Okay, and hopefully
I
sound
can
is
hear
okay?
it.
Okay.
Yep.
This is from the CDC.
Liver disease caused by the hepatitis B virus, referred to as HBV, can be either acute or chronic. The first serologic marker to appear in someone infected following exposure to HBV is hepatitis B surface antigen, referred to as HBsAg. HBsAg, shown by the red hatch line, can be detected on average 1 month after exposure to the virus, but can range from as early as 1 week to 9 weeks after exposure, and may precede the onset of symptoms by 1 to 2 months. Symptoms, when present, occur on average 12 weeks after exposure to HBV, with a range of 9 to 21 weeks. This period is noted by the green bar. When the serologic test for HBsAg is positive, HBV DNA can usually be detected in the patient's blood. The duration of detection of HBsAg and hence HBV DNA is variable. About 50% of patients will test negative for HBsAg and HBV DNA by 7 weeks after symptoms of acute illness have appeared. All patients who recover from an acute infection will be HBsAg and HBV DNA negative by 15 weeks after the appearance of symptoms. Hepatitis B E antigen, referred to as HBeAg, is usually detectable in patients with acute disease and is noted by the green bar. The presence of HBeAg in serum generally correlates with higher titers of virus and greater infectivity, while the presence of antibody to hepatitis B E antigen, referred to as anti-HBe, shown by the yellow bar, denotes lower levels of virus and thus less infectivity. A diagnosis of acute hepatitis B can be made on the basis of detection of IgM class antibody to hepatitis B core antigen, IgM anti-HBc. This serologic marker is depicted by the pink hatch line. IgM anti-HBc is usually detectable at the onset of symptoms and becomes undetectable within 6 to 9 months. Total antibody, IgM and IgG, to hepatitis B core antigen, referred to as total anti-HBc and illustrated by the purple hatch line, persists indefinitely as a marker of past infection. Antibody to hepatitis B surface antigen, referred to as anti-HBs, is depicted by the orange hatch line. Anti-HBs becomes detectable during convalescence and after the disappearance of HBsAg, and generally indicates recovery and immunity from reinfection. There is a period of time, often called the window period, which occurs after the disappearance of HBsAg and before the appearance of anti-HBs. During this window period, when using routine tests for diagnosis of acute hepatitis, IgM anti-HBc and total anti-HBc may be the only serologic markers present. There is also a period of time soon after exposure when these routine tests will find only the hepatitis marker HBsAg present. A person with chronic hepatitis B virus infection will have both hepatitis B surface antigen, HBsAg, shown in red, and total antibody to hepatitis B core antigen, total anti-HBc, shown in blue, persistently detectable by serologic testing throughout the duration of chronicity. HBV DNA will usually be detectable in serum as well, using a nucleic acid test, or NAT. Hepatitis B E antigen, HBeAg, shown in green, generally indicates higher levels of HBV DNA and thus greater infectivity. Presence of antibody to hepatitis B E antigen, anti-HBe, shown in purple, conveys just the opposite scenario. Chronic HBV infection is diagnosed when a patient has a positive serologic test result for either HBsAg or HBeAg or HBV DNA on at least 2 separate samples 6 months apart, or when a patient has a positive test for any one of these on a single sample and has a negative test for IgM anti-HBc. Successful vaccination against HBV infection results in production of anti-HBs, with seroprotection defined as an anti-HBs level of 10 milli-international units per milliliter or more 1 to 2 months after completion of the vaccination series. HBsAg may be transiently positive for 2 to 3 weeks after vaccination, but this is clinically insignificant. A serologic test result of anti-HBs positive alone indicates immunity following vaccination with at least 3 doses of hepatitis B vaccine. Without repeated exposure to HBV, antibody levels will naturally decline over time. but immunity is likely maintained even if levels decline below 10 milli-international units per milliliter. This table summarizes the interpretation of serologic test results for HBV infection. Negative results for hepatitis B surface antigen, HBsAg, total antibody to hepatitis B core antigen, total anti-HBC, immunoglobulin M, IgM anti-HBC, and antibody to hepatitis B surface antigen, anti-HBs, should be interpreted as never infected and therefore susceptible. Positive HBsAg with the other three tests being negative indicates early acute infection, but could also indicate receipt of the vaccine within several weeks. This is a transient effect. Positive HBsAg, total anti-HBC, and IgM anti-HBC with negative anti-HBs indicates acute infection. As acute infection resolves, HBsAg will disappear, and before anti-HBs appears, both HBsAg and anti-HBs will be negative, while total anti-HBC and IgM anti-HBC will be positive. Negative HBsAg and IgM anti-HBC with positive total anti-HBC and anti-HBs indicates past infection with recovery and immunity to new infection. Positive HBsAg and total anti-HBC with IgM anti-HBC and anti-HBs negative indicates chronic infection. Total anti-HBC positive alone with the other three negative has several possible interpretations, including a false positive result and therefore susceptible. Past infection resolved, low-level chronic infection, and unlikely to be infectious except under unusual circumstances involving direct percutaneous exposure to large quantities of blood, such as blood transfusion, or passive transfer of anti-HBC to an infant from an infected mother. Anti-HBs alone should be detected following vaccination, as described previously, or may be detected for 3 to 6 months following receipt of hepatitis B immune globulin, HBIg, also commonly referred to as HBIG. This segment is now complete.
All right. So I think I think that was really helpful, and I really appreciate Dr. Dawsey you sharing that resource. It's a good one for us to, I think, incorporate, and it's put forth by the CDC, which we like. Okay, so I think we wanted to open it up to questions. We can talk about the case I discussed at the beginning, and then I would like to really focus on the case that Dr. Dasu also submitted. So, so if we go back, give me 1 second. Here we go. All right, so if we go back to our 28-year-old woman, right? So we'll start here and just start. So let's start here. What tests, if this patient now you're seeing her, you've discussed doing a Hep B screening test. So what tests are we going to do for screening in this patient? This is where we're going to open it up to folks to chime in. What would be our step 1 screening tests? Anybody can, you can put it in the chat, or you can take yourself off mute, chime in.
Yeah, or you can raise your hand via Zoom, and Ponni and I will see it, and we can
there we go.
announce.
We have somebody who's raised their hand. Oops. Okay, and people are writing it in the chat.
Yeah, I think Anthony, Catherine did. Yep.
Yeah. Okay. Sorry, I don't see everybody's name on their screen. Rachel, who has their hand raised?
Let's see. It looks like Lydia does.
Okay, Lydia. Sorry about that. I'm going to unmute you, Lydia.
Oh, I didn't mean to have my hand raised, but I just have a couple of questions anyway.
Okay.
Is that for a question? Is that right?
So let me take your question in a second. So I think Catherine and Anthony and so I think folks have chimed in. So checking a surface antigen, a surface antibody, and a core antibody would be kind of the screening tests we would recommend, and that is correct. Lydia, what was your question?
Oh yeah. Well, what is the minimal test for a patient that is received the vaccination, and we know, they're a healthcare worker, so we know that they have received the vaccination. We trust them.
So we always recommend to check all 3 tests when we are screening. Yeah. And I think I touched on this on the last talk. There have been studies looking at people who report having had a vaccine, and let's say you were only going to check. So what tests would indicate that the patient has been vaccinated previously, Lydia? Let's start maybe there.
Oh, okay. Well, you would do the hepatitis B surface antigen, right? And the anti-HBC, actually the antibody to hepatitis B surface antigen, it should show immunity.
Yeah, so you're expecting the surface antibody to be positive alone, right? So let's say you only checked for that, and it comes back negative, and you didn't check the surface antigen and the core antibody, but one of those tests were positive. That would greatly influence how you would recommend, what you would recommend for this patient, right? Who's a healthcare professional,
right.
And whether or not you would recommend that they're cleared or that they need a vaccine. So it's really important to get all 3. Self-report, as much as we love to trust our patients, sometimes doesn't give us the whole picture. And I think Joanne just chimed in on the chat. We have had many non-immune serologies even after a history of 3 vaccines. And, that CDC video was really nice and helpful in that, that surface antibody titer can wane with time. I talked about last week that some people are inappropriately vaccinated without being screened. They fall into a risk category for having infection and are just given the immunizations without actually being screened first. And so that kind of misleads some of our people who are actually infected without getting tested first and being given a vaccine. And it really is that they are still living with, obviously Hep B infection. And then Joanne, you also said also positives for many of our immigrants who have had vaccines given but not screening prior. Yes, exactly. So that's the point we touched on last week, and I appreciate you sharing that again with everybody here. All right, so does anybody have any questions about those screening tests?
Oh, I have one more question.
Sure, go ahead, Lydia.
Okay, so in the uncertain scenario, that last scenario, what do you typically advise the patient? I mean, do you recheck it in 6 months? I mean, obviously you're not going to go ahead and do a biopsy of their liver right away in that uncertain scenario.
So yeah, so good question. First off, I would totally agree with you. I would never recommend a biopsy in somebody who's not surface antigen positive as a workup test for hepatitis B. So there are a couple of different options. One is to repeat the test serologies, maybe with some at least defined interval of time, to see if one of the interpretations of that test is if they're kind of in that acute kind of resolving infection phase, going into kind of an immunity phase. And that was highlighted actually quite nicely in that YouTube video that we just saw, that if you're in that window, right, where only the core antibody's positive, you may want to give it more time to see if that person develops that protective surface antibody. It also would tackle the issue of it being a false positive, right? So if you check it again, the idea would be, hopefully the second time around, it wouldn't be false positive again. That would be an extraordinarily rare circumstance to get 2 back-to-back false positive tests. The other test that sometimes is helpful to me to tell whether or not this is a really related to a prior infection that's resolved is to check the E antigen and the E antibody, and or also the DNA level. And sometimes with occult infection, that DNA level might still be present. And if the E antigen or E antibody come back positive, along with that core antibody being isolated positive, to me, that really, really suggests very strongly that that is related. The only reason you'd be getting the E antigen or the E antibody to be positive is that the body's seen or has, you know, has seen the actual virus. So it would go along with that most common interpretation, right, of the infection. If it's resolving, the E antibody would be positive. And if it's the E antigen is present, that might be a scenario in which, again, you're in this in-between phase and seeing whether or not the person is going to clear the virus or really have any signs of maybe occult, you know, infection. So repeating the tests and then doing some of those additional tests would kind of help you narrow down and reassure you about which scenario it is to be. Okay? So I do agree with that. Any other thoughts from the learners on what we just discussed here, or any questions? And Vikram, I know you've typed in a question, is there a panel for post-liver transplant patients? So we don't do anything differently in terms of screening in the post-liver transplant side. So we would still screen them. The one thing that's kind of a more esoteric topic as it relates to liver transplant is that we do offer Hep B core antibody and even Hep B core antibody livers, for example, to patients who are from a donor to a recipient. So we counsel our patients that patients who are isolated core antibody positive donors, where we don't find any detectable Hep B DNA, their surface antigen is negative, those are considered suitable donors for a recipient, so somebody who needs a liver transplant. And the way we deal with that after transplant, because actually the 5th talk in this whole series is going to talk about reactivation. And anytime your core antibody isolated positive, or core antibody positive period, there is a risk for reactivation in an immunosuppressive setting, which is what a post-transplant patient lives with. They're given immunosuppression medicines to prevent rejection. We basically put all of those patients who receive a core antibody positive donor on antiviral therapy for hepatitis B lifelong to prevent reactivation. So it's not that they are getting a poor quality liver or a liver that has actually Hep B infection, but we know in that setting of being core antibody positive and being immunosuppressed, there's a risk of reactivation. And so the 5th talk in the series is going to talk in more detail about reactivation. Vikram, does that answer your question?
Yes, thank you.
Okay, excellent. So, and certainly if people have questions, feel free to chime in. I did want to spend some time now moving to sharing the case that, again, Dr. Dasu was kind enough to share with us. So give me 1 second. I'm going to pull it up so that we can all look at it together. Can folks see my the case?
Yes.
Okay.
Yep.
All right. So let's go to the top. So Dr. Dasu, do you want to take us through this case, or would you like for me to walk us through the case?
You can introduce the topic, and then if need be, I will jump in.
Okay, sounds great. So this is a 55-year-old male. We don't have race on this patient, but we do have country of birth, which is Italy. And no household members who are referred. And it looks like this person has a family history of liver cancer or cirrhosis. Is it both or one or the other?
Cirrhosis.
Cirrhosis. So family history of cirrhosis. And does not look like they are currently on any kind of treatment with medications, and no other medical problems that we know of. And if we go down to the page 2 here, what we see are the serology results, and these are from August of 2018. And what this person came back, their test results with are surface antigen positive, they are E antigen negative, they are core antibody positive, and E antibody positive. Their Hep C test also came back negative, and a Hep B DNA test was done. So the screening tests here would have been the surface antigen, right? The core antibody and the surface antibody. And of those, we know that the surface antigen is positive. So this is somebody with active infection, and the core antibody is also positive or reactive. And then the additional tests, including the E antigen, were checked. And this is a person who's lost E antigen, has E antibody. And their viral load came back at 10,000 IUs per ml. So what is the I kind of gave away the punchline there. What is the diagnosis? So surface antigen being positive means they have active infection. Correct. Great. Thanks, Lydia. And then are there additional questions you would ask to assist in the diagnosis, treatment, or follow-up? So what are some questions you might ask a person who has these test results when you're having a conversation with them? Is there anything on the history you may want to know? So we know that there's some family history, right? Somebody in the family has liver cirrhosis. So what would we want to know? So would we want to know, I think one thing I would want to know is, you know, what degree relative this family history is in. I would also want to know who else lives in the house, right? And how is that information helpful, or how would we use that information? So Dr. Dasu, I'm going to come back to you. Let's say this person said they were living with a couple of other household members or family members.
Sure. Would we want to know, we probably would want to know their immune status as well. And if this was a relationship that was amenable to sexual transmission of the disease as well, because of the body fluid contact.
Excellent. Yep.
That definitely plays a role. And the social history of Italian origin was brought up because there's, from Dr. Perumalswami's presentation last week, we did learn that geographical location of your patient does matter because of their likelihood of disease. And we didn't discuss that yet, but it probably comes down into the further weeks. There's a genotyping correlation as well. Hep B, similar to Hep C, has genotypes, and they are endemic to different geographical locations as well.
Right. So, so one thing we didn't get into a lot of detail here yet is the genotype test result. And do people know that similar to other viruses, such as like hepatitis C, we can actually genotype this virus and we give it a letter designation with hepatitis B. And that letter designation can sometimes be helpful because, as Dr. Dasu just said, the geographic spread of hepatitis of B globally, in certain regions, actually certain genotypes are more prevalent. So you're more likely to see, the letter designations depending on different regions of the world. Any other questions you might want to ask? So we talked about the household members, knowing their status, getting them checked, particularly any children living in the household, but any household contact, any sexual contacts would also be recommended for screening. What other things might you want to know in this patient?
How do we rule out, this is a question that wasn't in the medical history in the chart. How do we rule out other causes of cirrhosis if HBV is not the case?
So this is really a question of, so once you've identified somebody with hepatitis B, and you're doing their workup and you find them to have cirrhosis, Dr. Dasu?
Right.
So, we always in medicine like to try to bring everything together under one diagnosis. I'd start by saying that. But, as you're pointing out, there are some things that have shared routes of transmission, right? So things that might put you at risk for acquiring hepatitis B might put you at higher risk for acquiring other liver diseases, such as hepatitis C. We certainly have patients in our practices where they have more than one liver disease present. And so typically I would screen for anything that has a shared route of transmission, and as well as HIV. So Hep C was checked in this patient, which would be good practice. The other things that might tip me off is depending on what the status of the hepatitis B is, and let me give you kind of one specific example. Let's say we have a patient who meets the criteria, and we're going to talk about this in one of the upcoming sessions, who meets criteria for antiviral treatment. And you put that person on antiviral treatment and their Hep B DNA level goes to undetectable, which is what we're trying to achieve with currently available therapies, viral suppression. But their ALT is still elevated, or they do have more advanced liver disease. And what you often should think about in that scenario is, one, does the cirrhosis fit with the context of which you're seeing this patient, number one. And so we don't have a test that tells us how long somebody's been infected or how they got the virus. So what I was doing with the probing earlier was I would try to ask about what risk factors this patient had and when. That might give us some clue as to the longevity, or at least the earliest time point at which a person might have acquired this virus. So if this person told me, yes, I have a history of unprotected sexual intercourse that goes back or happened back 20 years ago, and remember that to develop cirrhosis for most patients, it will take on the order of decades, right, to get to cirrhosis. The hallmark I always think about is, a decade a stage. The exceptional points would be developing cirrhosis in a shorter time period in somebody who has concomitant HIV infection. So if you've ruled that out, but let's say you're seeing a young person, right, with cirrhosis and Hep B, and we don't think that this is something that they acquired from mother to child because they're born here in the United States, don't have a high risk of, that puts their family at higher risk for Hep B infection. So I would be looking for something that doesn't fit the classic scenario. So somebody who is like an East Asian born patient, or somebody born in Africa who's coming to me in their 60s and identify Hep B and they have cirrhosis. To me, that would make more sense that the cirrhosis likely goes along with Hep B being the main driver there. But if I see, like, for example, a young person or somebody who says, I've had no risk factors up until very recently that explain why I got my hepatitis B, and they have cirrhosis, to me that raises a kind of a level of suspicion that is there something else going on? Do they have underlying fatty liver, which we're seeing more of? And I would do more of a workup to make sure that, and an ultrasound, for example, is a really nice test to do to look for fat in the liver. And I might check also other liver test serologies just to be certain. So I would screen them for less common things like autoimmune hepatitis, make sure that they don't have hepatitis E infection, for example, in the right scenario, something else that's causing them to develop cirrhosis at a very young age that isn't otherwise explained. Does that answer your question, Dr. Dasu? Okay.
Yeah, great.
Okay.
Thank you much.
Yeah, so something that kind of doesn't fit, seems out of the ordinary based on the history I'm getting and the age at which I'm seeing this patient if they have fibrosis markers that are putting them into a cirrhosis category. Yeah, and we do see more and more patients because of increasing, odds of finding fatty liver in our patients these days, more than one thing often going on in the liver. Okay. Does he need further workup? So you've checked the viral load, and I think in our subsequent talk that we can actually refer back to this case in another week or two when we start to talk about management, and we'll use this as maybe a discussion point for how we would take this patient and then turn it into an action plan. So I'm actually going to hold on to this case and come back to it in a future talk. Okay. And then, Lydia, you just typed in a question. Can you comment on the viral load in this case and the significance of the actual number? So this viral load level is used to help us determine what is the best management plan for this patient. And it varies depending on the different setting in which you're managing this patient. So for example, in a woman who's pregnant that you're screening for hepatitis B, let's say this was not a man, this was let's say a young woman of childbearing age, that viral load actually influences risk of mother to child transmission and would be a decision point for initiation of antiviral therapy. So the level of that viral load helps us determine who needs treatment now and who can potentially wait. And I'm going to talk about this in the fourth talk in this 5-part series. How it's used in pregnant women in talk 5, but in talk 4, we'll talk a little bit about what we do with this level and when we start antiviral treatment. And it's largely influenced based on your E antigen status and your fibrosis status. Okay, so that I'm going to save it for another talk to put it into the right context, but we'll be going into that in more detail, definitely. Any other questions folks can think of based on serologies, things that we discussed today, the core antibody being positive and how we interpret that? Okay, and there are a couple of new messages that just came up. Okay, question, due to an error on an requisition form, we have lab results for surface antigen, surface antibody, and core IgM, so not the total core IgG, on a hard to reach client. The client is experiencing homelessness and we do not have any contact info. Is it possible to interpret these tests? So Anthony, can you share what the results are for those tests that you have? Are they all negative or any of them positive? And you can type it into the chat as well.
Yeah, you could type it in, Anthony, or if you could take yourself off mute.
Okay, so they're all negative. So you could certainly counsel this patient if you were able to reach them. And this is a real life challenge. We screen a lot of patients and they have a lot of other things going on in their life that sometimes make it difficult to keep them engaged in even giving them the test results. So we struggle with this on a day-to-day. So they're all negative. So what does it mean if the surface antigen is negative? We can start test by test. So the surface antigen here is negative. So if that's negative, we would say that that person does not have active infection, correct? So that's one thing you can take from these tests. It's reassuring that the core IgM is negative because that would also rule out, what would that rule out if it's negative? I'll give folks 30 seconds to chime in if they want. If not, I will give the interpretation. So that would rule out acute infection. That is correct, Anthony. So you could tell this person, if you were able to reach them, that they don't have active infection, they don't seem to have any evidence of acute infection. But what it also means, if the surface antibody is negative, is that they don't seem to have protective immunity to hepatitis B, and therefore they may be somebody who is susceptible. So they've never been infected, although we don't have the core total, so they're at risk. And so therefore, right, Lydia, this is somebody you may want to counsel, if you were not able to get the core total, to offer them a vaccine to hepatitis B, if that could be offered to that patient or that person.